This session, I'm I'm caring a lot because it was part of one of the exercises that together with Dr. John Pascas and David Taggart we have done to try to improve and to offer something new to the audience. The idea is really conversate with industry and try to get them on the podium as well, not only to be on the booth, but listening from them. What is the future looks like? Sometimes we are telling you what we see for the future, but sometimes we want to hear from you, where is your point? And I think it's very important also for us in the current era to try to understand the industry point, to find the way to be successful together and advance this field of coronary surgery. I will introduce a mentor, a friend that is here with me, Dr. Sam Balke from University of Chicago. John Pascas, I'm sure, is coming very, very soon as well. But for the time manner, we will start with the first, that is a pre-recorded presentation from Campbell Rogers about AI-enabled quantitative plaque analysis will soon determine allocation of patients to medical therapy, PCI, or CABG. Please.
Good morning. Thank you very much for the invitation to participate in this meeting, and I wish I could be there in person. It's certainly a privilege to be able to join. The topic given to me today is that AI-enabled quantitative plaque analysis will soon determine allocation of patients for optimal medical therapy, PCI, and coronary bypass grafting. My disclosure is here. I am a full-time employee of HeartFlow. Well known to all of us, and as an important backdrop for this discussion, is that non-invasive testing for coronary disease, however it ends up in medical therapy or PCI or bypass, the current status, based primarily on functional testing, stress testing of one flavor or another, is rife with limitations. In particular, false positive rates, sending people to the cath lab, for example, only to find that they don't have obstructive disease. In the literature, would suggest that somewhere between 50 and 60% of patients who go to the cath lab. And then the other side of the coin, false negatives, where the literature would suggest, depending on patient mix, somewhere between 20 and 30% of patients who go out of the office with a, quote, negative stress test actually have lurking important, significant obstructive coronary disease, which may well benefit from revascularization. So this is the world in which, of course, we've all been practicing for decades. This world is changing and has changed. And the focus of this discussion is how it has changed towards coronary CT angiography, as well as adjunctive AI-enabled tools, including FFRCT and including plaque assessment, all derived from information hidden, if you will, in CTA, how that has now become a frontline test for symptomatic patients suspected to have coronary disease. If one looks at the guidelines, for example, the American Heart Association ACC guidelines from 2021, on the left of this slide, those guidelines elevated coronary CTA to be the only class of recommendation 1 level of evidence A non-invasive test for coronary disease. They also included FFRCT as a 2A recommendation. And more recently, the European guidelines, the ESC guidelines, which were published late last summer for patients with chronic coronary syndrome, also identified coronary CTA as a class 1 recommendation and elevated FFRCT to a class 1 recommendation as well, largely on the back of prospective randomized trials, which were published between the ACC guidelines in 2021 and the ESC guidelines most recently. Now, we're here today also to talk about coronary plaque assessment. And what you're seeing here is an AI-enabled interface which allows direct interrogation of coronary plaque burden and location and type derived from coronary CTA. And it includes elements of the plaque you see being scrolled on the screen now and cross sections on the upper right. And we'll see as that plays again. And the upper right cross sections identifying as the vessel, in this case, the LAD is scrolled, areas of calcium, areas of non-calcified plaque, etc. And finally, this plaque is not only localized and characterized, it's quantified. And you can see at the bottom on the right, for example, in the left main, there is 18 cubic millimeters of plaque in this patient, all derived from coronary CTA. And these measurements with the HeartFlow AI plaque assessment tool have been validated in a prospective study published in the European Heart Journal compared to intravascular ultrasound as the reference standard and found to be highly accurate. They've also found to be highly reproducible. So this information about coronary plaque as well as physiology is now all available from coronary CTA. And the question for today, the topic for today is how does this information guide management? Will these tools be the guide for medical therapy, PCI, bypass, triaging amongst those different options? So I'll show a few cases identifying different permutations, if you will. The first is this very interesting comparison of two patients who both are 63-year-old men, both had symptoms leading to a coronary CT angiography being done. Both coronary CTAs showed proximal LAD disease, as well as other areas of atherosclerosis. So they both had similar symptoms, similar demographics, prox LAD disease. Patient on the left, the FFR CT derived from the CT suggests that the LAD in the first diagonal territory have compromised flow. The FFR is 0.75 and more distally drops even lower, below the 0.8 threshold customary for FFR, showing that this patient has high near-term risk and by any guidelines, any appropriate use criteria, would benefit from revascularization. In contrast, the patient on the right has no compromise of flow, no FFR below 0.8. In fact, it's 0.89 distal to the proximal LAD disease. So he has low near-term MACE risk and undoubtedly would be managed with medical therapy. Now let's look at their plaque information. And the patient on the top, who had been on the left, who had very low FFR, has total plaque volumes, you see in the green circle, of 186 cubic millimeters. Most of it is non-calcified plaque. And if you look on the right, the nomographic data, which has been published, would suggest that puts him somewhere in the 30th percentile for 63-year-old men. In contrast, the patient who was on the right on the prior slide with the FFR CT, which was negative, has a much higher burden of coronary plaque, nearly 600 cubic millimeters of plaque. It puts him approximately at the 70th percentile for 63-year-old men. So he has much higher long-term MACE risk related to this plaque burden. And I think it defies logic that these patients would be managed the same way. First patient on the top needs PCI. Second patient on the bottom probably needs much more intensive medical therapy than the patient on the top, all informed by this quantitative assessment of coronary plaque derived from CT. Now, the medical therapy for the patient is also increasingly informed by these plaque measures. So what you're looking at here is a chart from an ongoing registry called the DECIDE registry. And this registry is looking at, in about 20,000 patients, medical therapy and how it can be informed and altered by the plaque information. So what you see are different tiers into which patients are placed based on total plaque volume, and then biomarker goals according to each of these thresholds, nomographic information and how somebody, even with relatively modest plaque, if they're above the 50th percentile, they may be considered to have more intensive therapy. And finally, some very specific treatment options, and certainly beyond the discussion this morning, but this world of anti-athero medications for coronary disease is, of course, exploding, as we all know, with new classes of drugs and new participants in existing classes of drugs. All of this being sorted by, in part, the plaque volumes derived from coronary CTA. Now, there has been a study published looking at how is optimal medical therapy impacted by these CTA-derived indices. The study was called the DECODE study. It was published earlier this year in the Journal of Sky. And in it, 100 patients with CTA and demographic information were presented to physicians, and they were asked to develop a medical management plan based on the staging system on the right, which had been published previously. Then the plaque information was shown, and the question was asked, will your management of these patients change based on the plaque information? And the answer to that was yes, in 66% of patients, where the medical management changed based on this quantitative plaque information, in a way that likely led to more optimized medical therapy. Usually the change was towards more intensive treatment. Now let's look at more complex disease and how this information can be helpful in triaging. So I present for your consideration this patient. It's a 57-year-old woman who had symptoms, a calcium score of over 800, and her CT angiography revealed some left main disease, diffuse LAD disease, and focal stenosis in the circumflex in a large marginal branch and in the right coronary in the mid-vessel. Her FFR information, which you see in the images on the slide, shows that in the LAD, this is all non-invasive information, remember, in the LAD, although there's lots of athero, there's a relatively slow decline in FFR. Although it reaches a low value of 0.76, there's no single focal area of drop. In contrast, in the circumflex marginal and in the mid-right coronary, it drops very abruptly. So now this patient goes to the cath lab, and the physicians knowing and the patient knowing there's diffuse LAD disease. We'll confirm it on cath, but there's probably nothing there that warrants PCI. The circumflex and the right coronary also have low FFR, and the LAD has low FFR. So now I'll share with you her cath, and just as anticipated, her LAD has diffuse disease. There is nothing focal that one could put a stent in. Her right coronary, right after that acute marginal branch, has a severe stenosis, and the circumflex has a severe stenosis in a large branching marginal branch. So based on this information, informed upfront, she was referred for bypass surgery based on the diffuseness of LAD disease, as well as the need to revascularize the other two distributions. And I would ask you to consider how different this triaging is, knowing this information up front, than had she gone to the cath lab simply, well, she has a positive stress test, we're going to cath her and sort of see what's there. Finally, the last couple of minutes, a little bit of data about overall populations and what happens in the prospective precise randomized trial, which was published in JAMA late last year, just about a year ago. These pathways were compared with a primary endpoint of about 2,000 patients, randomized a primary endpoint of a composite of death, MI, and negative cath. That composite was reduced 70% by using this combination of CT and AI-informed tools after CT, as compared to a traditional pathway of stress testing or taking people directly to the cath lab. That's observation 1 from PRECISE. But I submit to you also observation 2, which is on this slide and is in the publication. The question is, how well does stress testing detect patients who have obstructive coronary disease? And as mentioned very early on, the literature would say somewhere 20 to 30% of patients may have false negative stress tests. In this case, the data say the following, that in equal populations, randomized studies, a little over 1,000 patients, doing CT, the numbers on the right of this slide, found twice as many patients who required revascularization than doing stress testing. That's on the left of the slide. So twice as many patients, and the patients who were being missed by stress testing, lest you think these were patients with distal lesions, small vessel disease found by CTA. Anything but. The patients on the left were patients you see in the green box. The difference was patients with high-risk anatomy, left main, multivessel disease, proximal LAD disease. That was where the difference lay between these two pathways. Finally, and of course of great interest to the group there today, this notion of how does one potentially triage people into the operating room for bypass surgery based on this incredibly rich information about CT and plaque and physiology. And of course, I expect most are familiar with Professor Soroiz's wonderful study published earlier this year in the European Heart Journal, in which this was done. And 114 patients were brought into the study. 111 went to the operating room based only on CT findings and FFR CT findings and visualization of the plaque, et cetera. The primary endpoint of the study, which was graft patency assessed by CTA at 30 days, was 92.6%, certainly on par with other benchmarks looking at graft patency following bypass surgery at this time point. And this study allows the hypothesis for sure that this may be a pathway which can avoid the need for invasive angiography in patients where CT is demonstrative of disease that may warrant bypass surgery. So hopefully this has been helpful. I wish I could be there in person, But the notion that these AI-enabled tools, plaque analysis and physiology, will determine allocation of patients to OMT, PCI, and bypass surgery, I mean, it's happening now. It's happening in randomized trials. It's happening in some sort of more forward-looking practices on both sides of the Atlantic, and certainly look forward to future meetings and providing updates for the group on the outcome of these ongoing studies in this area. Thank you again for the invitation to participate.
So I will make a very short comment, and I think it's a summary of something that we heard beautifully explained by Patrick Serrois at the early beginning of this meeting. A lot of time when I speak with industry and with all of you, there's always this question, what is the future of number of coronary artery bypass grafting? We've been stagnant for years, the numbers are the same. Reality is, as we are hearing, two major disrupting technologies, two major changes are coming. These imaging are going to first detect coronary artery disease way earlier and allocate patients and giving back, not to the interventional cardiologist, but the non-invasive cardiologist, the power to allocate that patients to the right therapy. So eliminating one of the bias that has been the most important determinant in the discrepancy between PCI and CABG performed around the world. So this is a moment in which, and we are expecting to see a growth in the number, and that's why we are saying the coronary artery bypass grafting is still very healthy in 2024, and it will still be very healthy in 2034. These technologies are here to change the way in which we are diagnosing and probably allocating patients to the right treatment.
Yeah, I can tell you that, well, first off, I'm sure you all were very impressed. Campbell Rogers is an exceptionally intelligent guy, and the leadership of HeartFlow, they're really on the ball. I had the privilege of being the only North American surgeon enrolling patients in the fast track trial. I did 12 of those 114 patients. And I can tell you that it is absolutely possible and in fact easy to do coronary bypass grafting, even very complex coronary bypass grafting, without an invasive diagnostic coronary angiogram. And those were the 256 slice scanners. We didn't have a photon counting scanner. So with photon counting scanners, that will take it over the edge to be a simple statement of fact that you get better images and better guidance for surgical revascularization with a CAT scan than with an invasive angiogram, full stop. So the notion that that every patient will need to have an invasive coronary angiogram will soon be false. And the notion that will be the gatekeeping mechanism for decision to allocate patients to medicine, PCI, or coronary bypass will also cease to be necessary. There will be obviously local politics as always, but things are changing dramatically, and this imaging modality will be an incredibly disruptive force. If I were a non-invasive cardiologist specializing in nuclear scans or MUGA scans or SPECT scans, I'd be retraining. And if I were running a heart institute, I would sell those things while there's still a secondary market.
Can I make two real quick comments?
Because in 2 years you have to pay someone to take them away.
I want to make two quick comments about this. One is, how many of you have ever gone into a chest and not found a suitable target on the LAD somewhere? There's always a target. One of the knocks against this type of technology is that I need the angiogram to actually see the quality of the vessel that I'm going to be bypassing into. Once you're there, you're going to be able to find the target. And the second one is coupling this with what Patrick showed us yesterday with the myocardium at risk. Yeah. I think it's going to be extremely powerful technology that will make everything that we do today somewhat obsolete.
Absolutely. So
our next speaker, unfortunately, was not able to make it, Dr. Trehan from Medanta. So we're going to move on to Peter Kapitein, a good friend, future of coronary surgery beyond the new robotic platforms. Everybody knows Dr. Kapitein, Vice President and CMO of Medtronic. Peter.
Thanks very much, and thank you very much for the invitation. And Gianluca not only has changed in the fact that he is organizing these sessions at 7 o'clock in the morning, but he even drinks British coffee now. So that is a major change. Now, you asked me to tell you a little bit about the future of coronary and cardiac surgery. And of course, I don't have the crystal ball, but I will do my best here. So of course, we also face with challenges. They're not only opportunities. So start a little bit with the grim view on this one. So what are the challenges? Of course, there's competition always from less invasive procedures. Patients want to be out of the hospital fast. They want to be home fast. And that's, of course, with PCI, but also, for example, with TAVR, that is the attractiveness. So you have to compete with that. You have to show that you're better. But at the same time, there are new technologies that we have to integrate into our practice, which is not always that easy because your people are trained in a certain way, they practice in a certain way, and a lot of them do it until they retire. Now, what is important, therefore, is training and skill acquisition. So how do you train people who have been used to do, for example, a coronary bypass operation for a long time? You have to retrain them, but also make sure that the new generation gets trained on these new technologies, which also might be more difficult than for the more senior ones who have not been trained on these new technologies. Now, we also talked a little bit about the gatekeepers. The previous talk was already about it, that who sees the patient first. And we have discussed it very often among surgeons that, we are always a little bit waiting till what will be sent to us by the cardiologist. So that interdisciplinary collaboration, the heart team discussion, is essential to triage the patients to the right therapy, not only for coronaries, but also for valvular heart disease. And then, of course, there's economical pressures. Can we integrate every new technology into our daily practice? Which, of course, is always a little bit more expensive. And at the same time, there's declining workforce. At this moment, something that is really we have to put more on the agenda is that how can we deal with less people being in the OR, being in the cath lab, and how to get patients to the clinical care pathway faster. Because in the future, and in the Netherlands actually there's already discussion that when you become 80 or 85, you need a hip replacement, you will not be able to get it in the near future because there's nobody who can take care of you. So that's another thing. Now, the reason for that is that the pyramid, the population pyramid, is something we have to take more attention to. So if you look, for example, in Western Europe, a lot of people are what we call the baby boomers, and maybe more people around the table, except for Gianluca, and I'm also a baby boomer, will become 65, 75, and we need people to take care of us. And you see that the pyramid is going, getting smaller and smaller towards the younger population. That means that nobody is there to take care of us. Now, if you compare it to Africa, which is, of course, completely different, you see a lot of young people there and very few older people. Now, just to put that into perspective, but at this moment, there are 12% of the people in the healthcare sector working in my country, in the Netherlands. And the prediction is that in 2030, there must be 20%. And not only because there are more patients, but also because there's declining workforce. So how to take care of the people that need you in the hospital? Now, this was a little bit, let's say, the more negative side, but there are a lot of opportunities for cardiac surgery. Now, take into account, that it was not that long ago that these pioneers, shaped the future of coronary bypass surgery. And you can point out to a lot of these pioneers also for valvular heart surgery. Now, what can we do in the coming years, and especially the younger generation? So I want to give you a couple of opportunities where you can concentrate on. So the first one is minimally invasive and robotic approaches to coronary surgery and valvular surgery. It is more attractive, patients get out of the hospital faster, you can use the robot in lots of different ways. Now this is just a picture, a video that shows you all the robots, and this is just one room in the facility for Medtronic in Boston, and you see there are a lot of robots standing there. And sometimes they start moving without somebody touching it because somebody from London is testing something in Boston. So that remote surgery will become even possible. And you see me playing with the robot as well. So that will come. Now, when will it come to cardiac surgery? Of course, first nowadays they're concentrating on urology, gynecology, but then of course I think the advantage for cardiac surgeries is that all the diseases that all these new technologies have will not be tested in cardiac surgery patients, but will be tested in patients where if there's something that is not optimal, you can tolerate it. In cardiac surgery, you don't have any tolerance there. If something is bleeding, everything has to work perfectly fine. Now, the second opportunity that we have is global health opportunities. And if you look at this is the world population, the growth of world population. At this moment, in 2024, we are almost at about 8 billion people on the planet. You see in this graph that at the end of this century, we will be more than 11.5 billion people on the planet. That means there will also be more patients, and there will be countries that in the future can afford cardiac surgery, like China, India. You see that the enormous growth also in these kind of procedures. But also Africa. I mean, the population there is growing very fast. Economy is growing there fast as well. So they will be able. So we need to train those people as well in those countries to be able to do cardiac surgery. Now, at the same time, there's an increase in cardiovascular disease. So obesity is increasing, diabetes is increasing. So what you will see now, the cardiovascular demand is, the forecast is that it will grow by 8% inpatient for demand for cardiovascular disease treatment and 25% outpatient. Now, what does it mean for coronary surgery? We expect also that there will be about a 4% increase in coronary surgery because of the increase in cardiovascular disease in the coming 10 years. So although we may say it's more or less stable, it will grow further in the coming years. The third option that you have, you can apply artificial intelligence and data analytics into your practice. Now, it may add in the diagnosis, as we have just seen in the previous talk. It can assess the treatment or severity of coronary disease, but also valvular heart disease. Then furthermore, it can help, if my button helps as well, improve patient identification and access to treatment. So you can better triage patients. Where should they go to? Medical therapy, a PCI, or should they go for coronary bypass surgery? You can determine the appropriate type of valve repair, for example. Does the patient need a mitral repair or mitral replacement? Then, furthermore, real-time AI can identify your instruments while you're doing, for example, robotic surgery. But it can also help in decision-making. What type of repair should you do? Should you do a P2 resection? Should you use neocords, etc.? And then, of course, it can also identify, here's the artery, there's the vein, and here is the best location where you need to place your neocords. Now, furthermore, you can streamline technology, allowing for remote access. So people can already now, at their iPhone, they can help somebody in the United States or vice versa, to say, well, maybe you should treat this patient in this particular way. And then, of course, last but not least, but very important, you can predict patient outcome. Is this patient really suitable to undergo surgery, or should we do something else here? Now, the fourth opportunity is you can think about improvement on ECLS and regenerative medicine. And it goes a little bit further than just, putting the patient on ECLS to support the cardiovascular system. You can also think about, you can apply therapy into your ECLS for heart tissue regeneration, use stem cells to regenerate damaged myocardium, and therefore potentially reduce the need for heart transplants. And it could also help improve the patients after a heart attack. Oh, this is a little bit, okay. Cardiac tissue engineering can also help you in, for example, make vessels that you need as a conduit for coronary bypass surgery, but also for heart valves. Let's see, okay. Then it can revolutionize transplantation. Ultimately, the dream is that you can create whole organs for transplant. So, for example, a kidney or a heart or a liver. And then, of course, ECLS will become more important also for acute respiratory failure. We see more patients coming. We had the COVID pandemic, but most likely there could be a new pandemic not so far from now, where you also need to support patients for respiratory failure. And then, of course, what is the means of ECLS for patients in cardiogenic shock? In Rotterdam, where I'm from, there's already an ECLS system on a helicopter, so that when they fly to the patient that had a heart attack and is resuscitated, they can put the patient on ECLS to transport the patient then later to the hospital. Now, the fifth opportunity is there's a focus, you can focus on the aging population and complex and more advanced cases. Now, this is just from the UK, because we're in the UK. You see the increase of life expectancy from 1960, where it was around 70 years, up until this end of the century. The mean age will be about 90 years. People will become older, they have more comorbidities, they have kidney disease, they have lung disease, they are frail, and then, of course, that will also mean that you will see more patients that are more complex. Not only that they have coronary disease, but they also have valvular disease, they have AFib, for example. Now, the sixth one, of course, is device innovation. That's a little bit upon us, together with you, how to innovate devices. And this is a good example how Medtronic started. In the late 40s, there was an engineer, Earl Buchan, who worked with a surgeon, cardiac surgeon, Walton Lillehei, in the University of Minnesota in Minneapolis. And they both worked on the first battery-operated pacemaker. And that's how physicians and engineers work together. Now think about if you would have unlimited resources, what device innovation would you like to envision or dream of in the coming years? Now I'll give you a couple of examples. For example, you could think of a polymer heart valve. You know, we all struggle still with a biological heart valve. You don't need anticoagulation, but we know there's a limited durability to it. Now, what if you would have a valve that would last lifelong, where you don't need anticoagulation? That would, of course, be great. So you could reduce calcification, more biocompatible. You could think about storage and availability. They would be there, you know, on the shelf for forever. You don't have a lifetime for storage. Lower thrombogenicity, so less stroke issues, and you can customize them. Now we have a 21 valve, a 23 valve, and a 25 valve, but we don't have a 22 or a 24 valve. Now this would maybe allow you to have the valve tailored to the patient's need. Now then, of course, you know, if we talk about coronary surgery, what about a coronary anastomosis device? And I know Glenn from one of the companies in the Netherlands will give also a talk later on. It might be more precise and more consistent, the anastomosis. There will be reduced trauma maybe to the vessels as well. It's more time efficient. You can do it faster than just a hand-sewn anastomosis. Hopefully, of course, the ultimate goal is also that patency will become better as well than, you know, with it, when you make the anastomosis with a suture. Now, this is, of course, everybody will deny in the audience. The surgeon fatigue, we don't know that this exists, but of course that also exists and can help the surgeon as well to do more cases, for example, during the day. And it's less dependent on the surgeon's skill. Now the training or to do a perfect coronary bypass anastomosis takes a long time. Now maybe you can learn the residents to do this faster and because the skill is less dependent here. And of course, ultimately the goal is that you can use a less invasive approach. For example, you can use a robot. You can not only do the Lima to the LAD, but maybe also to the backside of the heart or a right coronary bypass graft as well. So this could all be dreams for the next future. Now this is another company from the Netherlands.
3mm vessel incision. Activating the applicator expands the stapling head, ensuring precise tissue alignment, and secures the vessel wall with the deployment of fine staples. In step 2, the same procedure is repeated on the coronary artery. Inspecting through each connector half's orifice now offers clear visual confirmation of patency. In step 3, the anastomosis is completed by snapping the connectors together with a one-way.
So this is all preclinical still. So this will still take about 1-2 years before there will be clinical application of this device. But again, shows you that there are already startup companies working on making this possible. This is then how it would look like. This is an animal experiment. And of course, a perfect anastomosis. Now, AMT is the other one, a company from the Netherlands, that is working on a coronary anastomosis. And they already have clinical applications. So they have already done studies in patients with Lima to the LAD and diagonal branch. So this is the Elena clip from AMT Medical. But Glenn will talk about this in more detail in the next talk, where you see that they use a clip and a laser catheter to make the connection between the vessel, the coronary vessel and the bypass graft. The beauty of this technology is that there's no interruption of blood flow necessary to make the anastomosis. So that is pretty unique here. Now, the other innovation that Medtronic, for example, is working on is left atrial appendage closure device, and also working on the next generation mitral. Pendature has already launched in the US and Japan, and will soon be launched in Europe. Now, the other thing you can think of about new training techniques that we need in cardiac surgery. So you can use virtual reality and augmented reality to train the next generation of surgeons, and maybe before they start operating patients, they can already see what they need to do for their mitral repair or their coronary bypass graft, and how to do that perfectly well. Train in data analysis, machine learning, that's something we need to make sure the next generation uses this in the correct way. And AI in diagnostics, treatment planning, and patient monitoring. How can you use that? And then, of course, the other thing what we should not forget, we also need to train the next generation in communication and leadership and teamwork. Something that was maybe not so much the focus in our time. And then, of course, what will be important to keep training and keep sure that you're on top of the new technologies that are introduced in the specialty. So lifelong learning is important, ongoing education, but you also need to recertify so that you can show that you're still able to do the perfect operation. Now then, of course, last but not least, leadership transformation. That will need to take place as well. The old way of doing surgery and running a department will probably also be over. So there's more room now for collaborative leadership. We have to offer opportunities for younger surgeons to learn, grow, and advance their careers. We have to recognize the importance of work-life balance, something that we have forgotten. That's why we start now at 7 o'clock in the morning on a Sunday. But that will become more important as well. And then, of course, we have to recognize that at this moment, there's already 50% of the physicians are millennials. And Generation Z is coming very quickly. And the baby boomers get less and less and less baby boomers there. So, but the younger generation appreciates much more transparency and open lines of communication. They want feedback, they want to communicate with you. And it's not like you say you should do this exactly in this way that they will accept that just without having a discussion around this. Then the other thing is that, in the past maybe also some surgeons were also motivated, not only, but also motivated by the financial aspect of the work. And then the new generation is not so motivated by that financial aspect of work. It's more the sense of what I'm doing, the purpose why you're doing this is more and more important. And then they want regular feedback. They want to hear from you, am I doing fine? Should I improve somewhere? Instead of, you just go to another case without discussing how they did the previous one. And then we have to actively promote and support diversity. At this moment, in the Netherlands, 70% at medical school are female students. And if we don't adopt the females into our specialty, there will not be cardiac surgeons in the near future. So we have to have more females coming into equity, and inclusion is very important. So this is baby boomers, it's 1946 to 1964. You see the Generation X, who are a little bit in between. The millennials, as I said already, 50% of them are now in the healthcare, and Generation Z is coming very fast. But of course, they have different work-life balance. So this is the baby boomer, Dr. Puskas, going to work, Generation X, millennials, and then Generation Z. Of course, this is exaggerating a little bit, but we have to acknowledge that there will be different generations that have different values. Now, so therefore, it is not so easy to predict the future, but the future of cardiac surgery, I think, is bright. There are lots of opportunities here for the next generation. And I remember very well, we had a dinner in New York when Dr. Puskas came also, and he said, you have to work on an anastomotic device. That will change the landscape of coronary surgery dramatically, and I think he's right. But it's not that easy to predict the future. As you can see here, but there's no sound. Can the sound a little bit louder? So, of course, with the new presidency, he said, sit, sit, and the dogs obey him. But it's difficult to predict the future also with the new candidate.
Excuse me, sit down. You weren't called. Sit down. Sit down.
Yeah. So that was what happened in the past with residents. That is over these days. Yeah, thanks very much.
Very good.
Peter,
question,
very entertaining as always and informative as well. You do recall correctly our more than one conversation about the importance of a facilitated anastomotic device and specifically one that's integrated on the arm of Hugo, or intuitive, which is conspicuously absent at this meeting. You know that the robotic lobectomy was an unusual event, a very unusual operation, until Intuitive incorporated a stapler on the end of a robotic arm. And then within less than 5 years, robotic lobectomy became the norm. Right now, TCAB, especially beta TCAB, is a very unusual procedure. If lightning struck this podium, 3/4 of the production of the globe in robotic TCAB would be killed. And that's just if it misses me. But if you, with Hugo, took a leadership role in incorporating a functional 21st century device on the end of a robot that's not committed to the prostate but is committed to the heart, you would change the world. It's true that the heart moves and the prostate, for the most part, does not. And that produces different technical challenges. But I throw down the gauntlet again and challenge Medtronic, led by a cardiac surgeon, to get on with it.
Absolutely. Yeah, no, that's why we're extremely interested also in the next talk from Glenn about coronary anastomosis device, because that will enable it and make it much easier also to apply the robot in cardiac surgery.
I've done this a dozen times, but if everyone in the audience would humor me, look at your cuff of your sleeve. You see the stitching at the edge there? Every surgeon in this room thinks they sew really, really well. Please raise your hand if you think you can sew better than the stitches on the edge of your cuff of your sleeve. No one can. That's a machine.
Right. Yeah.
Right? The cuffs used to be sewn by hand, and then the sewing machine was invented.
Yeah.
Peter, there's also, if I could add to what John said, there's a device that is ripe for the taking. The patents have expired. I used it on thousands and thousands of anastomoses with excellent results, and it was taken off the market. It is available. The engineers are around. It's called the Seaport Cardica device. You know it very well.
Yep.
And I would put it on your radar. Think about it. Obviously, the ones coming out of Utrecht are going to be very exciting.
Yep.
But all these things are extremely necessary.
Yeah, absolutely. Okay, great. Thanks very much.
Thank you. One question, please.
I was just going, nice talk. Just two quick questions. AI, I think AI still doesn't think for themselves, so they take the bad experience. And I know a lot of the experience in cardiac surgery and minimally invasive robotic, it's a bad experience because only few people do it. So how can we don't have the bad experience that we know in history get into the AI? Number two, the reimbursement. One of the things I think, great. I strongly believe that the anastomotic devices and these things are very vital for us. But when I look at some, like for example, when Impella came out, the reimbursement for that was huge. But when it comes to cardiac surgery, the reimbursement for the cardiac surgeon is much, much less. So how are you going to convince the newer generation who want to work less and enjoy their life to work harder on certain things and then get them less reimbursed?
Absolutely excellent question. So AI, of course, not really everybody knows what AI means. I always make the joke that if you want to have an abstract accepted at a meeting like this, put AI in the title, even if there's no AI, and it will be accepted because everybody is very enthusiastic what AI can do. So how to apply it's something we still need to learn and work on. But of course, it could become very helpful in using AI, especially in decision making and what type of repair, for example, do you need to do. There's already efforts going on that you analyze the mitral valve leaflets and it can tell you or help you, guide you on what type of repair you can do for this particular patient. The second one is also very important, the economical pressures, integrating a robot. Now, of course, everybody will say if there's more competition, the prices will go down. That's one reason. So there's already about 80 companies working on a robot. And there's even an Indian company who's working on a robot specifically for cardiac surgery. So that will also make more competition and drive the price down. The other thing is that if you can get your patient to the clinical care pathway faster, that means patient will need less days in the hospital, less days in the intensive care. And that would also reduce costs, of course, at the end of the day. But that's something that needs to be proven as well if you integrate those new technologies. So you need a couple of pioneers, like here behind the table, that tries to see what the advantages, disadvantages are of robots, where we should improve. But then, of course, it will hopefully become available for the broader public. Yeah. Okay. Good. Thanks.
Thank you.
So unfortunately, our good friend Sudhir Srivastava, although he made the trip to London, is not able to get to the podium this morning. He's not well. And Sam Balke is going to deliver his lecture and introduce a new robot that Sudhir has truly pioneered in India.
Thank you, John. So I'm not Sudhir Srivastava. But I do know a little bit about the system that he's invented and is the CEO of the company SSI, which is manufactured in India. And I'll try to go through the slides very quickly so at least we can have a conversation. He's here at the meeting, but he couldn't make it this morning. So the Indian robotic surgery scene, which was what compelled Sudhir. Sudhir is a good friend. Everybody knows him, I think, in this forum. Was kind of the pioneer of beating heart TCAB back in the day, and found himself thinking about the rest of the world, and came to realize that he wanted to innovate and create a system that could be used in countries that may not be able to afford expensive robots. And he has been able to achieve that dream, and now the company exists. The robot is manufactured in India, and it is very surgeon-friendly. And Sudhir is a cardiac surgeon, so for those of us in this room, he is somebody who has been able to marshal his experience in cardiac surgery to be able to make instruments that I'll show here really quickly that afford us the ability to use the robot in cardiac surgery, in addition to everything else. So these are the factors that he thought were responsible for the low adoption of robotic TCAB, which is my passion. And you can see here a list of things that we all talk about all the time. And he set out with his mantra SSI system to overcome some of those challenges. One of the most important one is the high capital and per procedure cost, which he aimed to rectify. And so in his mind, what is needed to increase the adoption of robotic cabbage is commitment, patience, practice, persistence, in terms of mindset, but also from the technology standpoint, an endo-wrist stabilizer that can be effected from the table or from the console, as staplers and other anastomotic technologies. This is the SSI mantra. It's a modular system similar to Hugo and can be basically adopted with 2 or 3 or 5 arms, depending on what the operation is, and the arms can be arranged around the table in various positions for the procedure. These are some of the features of the arms. They are very flexible. They are stable and have advanced touch screen controls. One of the unique things about this system and Hugo as well is that you don't sit with your head inside of a console as we do today with the Da Vinci system, but you sit back and wear a set of 3D glasses. And the rest of the team can also see 3D, which is very important. Telesurgery is a feature of the SSI mantra, and Sudhir tells me that just recently he was able to achieve certification from the Indian government to perform telesurgery, and he's planning to do some of that in the near future, and that's very exciting. Telesurgery, for those of you who don't know, first happened in 2001, the famous procedure that was done between Paris and New York, cholecystectomy, the Lindbergh operation, they called it, and then that kind of died because of the fact that the company that was promoting it, which was Computer Motion, basically got gobbled up by the big company Intuitive, and it was not in their best interest, according to their analysts, to continue along this path. But this has now made a resurgence, and telesurgery is now a real thing. It's happening in China, and it's happening in other countries. This is the SSI mantra vision cart. The endoscope is made by Olympus, but it's unique in that it flexes up and down, so you don't have to take it out and put a new one in. And these are all the multi-specialty instruments that they have come up with. They're very nimble in terms of being able to come up with new instruments on a very short notice based on surgeon recommendation. And for us, the most important thing in my mind is the cardiac instruments, and you can see here a panoply of the things that we use for the various procedures. You see a dynamic atrial retractor that we use for mitral valve surgery. To the very far right is the endo-wrist stabilizer, and then below you have the automated anastomotic connector, the NADI, which is similar to the Seaport device which we have used, but has some features that are different. And then to the bottom left is a multi-fire clip applier, which was not available on the previous generations. If this video plays, it will show us how the NADI works, and if any of you have seen the Seaport device, it's very similar to the Seaport device, but has a smaller profile and can probably fit into a smaller port. When I was using it in a TCAB setting, we would need a 15-millimeter port to bring the Seaport device in. This one can come in through a smaller port. It has an integrated knife and a set of staples. This is an interrupted coronary suture that he's working on. And then finally, a quick show of the clinical experience. Sudhir did a TCAB with his Mantra device in 2023 in India. And just recently, this is another case that he did in Jakarta. And this is the SSI Mantra 3, the third generation of the device. And you can see the open console. And the instruments, the effector ends look very similar to Da Vinci. This is an ASD with a patch. I think there's a TCAB at the end of this. Maybe it's on the next slide. Multi-specialty, they've performed a total of 2,600 procedures with this, and you can see the majority are obviously general surgery and urology, but over 100 cardiac procedures. And these are the cardiac procedures that were done. Excellent results with very low injuries. And then teleproctoring and telesurgery are the promise here, otherwise known as the SSI Guru. And that's Sudhir proctoring somebody that's doing a procedure. And this is the first ever telesurgery that he did, I think just very recently. And the latency, which we always talk about with telesurgery, was 41 milliseconds. This is from SSI headquarters in Delhi, operating on a patient across town. And then finally, there has to be a bus, and you can take this remotely to the various places and have the system inside the bus. I just wanted to make sure that we all were able to see what Sudhir has been doing, and again, he apologizes for not being able to be here. Thank you.
Yeah, we are the International Society for Coronary Artery Surgery, and we are really excited to promote this kind of work all around the world. If it's not going to happen in Minneapolis, then it'll happen in New Delhi. We talked about taking that device, that's a knockoff of the Flex A on the end of the Hugo, a knockoff of the Hugo, and it's happening now. Either develop it or end up buying it for a lot of money later, or they won't have it for sale. Another comment, I think that the newer robotic companies in the developed world, for lack of a better term, focusing on the prostate is a mistake. That's a mature market with an embedded competitor. Focus on the coronary market. And don't think about how many TCABs were done last year by these two guys. Think how many multi-vessel PCIs were done in the world. Because if you can make a robotic TCAB operation, a beta TCAB operation feasible, then beta TCAB hybrid would become the most common form, most desirable form of multi-vessel revascularization. So if you're doing your business models around just how many TCABs were done last year, you're not thinking right. That's not the market. And if you think you're going to elbow your way into the prostate and make a fortune, you're sailing a fortified mountain. Just my perspective on the business environment of robotic cabbage.
So I couldn't agree more. But we go to the next speaker of the day, and it's a real pleasure for me to introduce Håkon Christian Grote from Medistim. He's the Chief Innovation Officer. I had the pleasure to spend time with him in our hospital. We had a great time for thinking about the future of this TTFM, and he will speak about future innovation in TTFM for CABG. Welcome.
Thank you for that kind introduction and this opportunity. And good morning to you all. The Rosetta Stone was discovered by French soldiers fighting the British over control over Egypt back in 1799. And what is special about it is that it has the same text in 3 languages, hieroglyphs at the top, demotic in the middle, and Greek in the bottom. And knowing Greek, we were able to decipher hieroglyphs for the first time for centuries, and by doing that, opening the door to understanding ancient Egyptian culture and history, a huge achievement and breakthrough. And Medistim is now on a quest to decipher the Rosetta Stone of TTFM. Please bear with me. There. An important tool for us in doing this is machine learning. And roughly speaking, machine learning can be divided into supervised machine learning and unsupervised. And supervised machine learning, the mechanisms in there are very similar to those of hypothesis testing. When you plan a study, and you all know this, you make a protocol, and then you capture data using that protocol, and end up with well-annotated data that are suited to test your planned hypotheses. For instance, if you have a LITA LAD and then the completion control measure a flow of 30 milliliters and a PI of 1.5, you will find support in literature, a lot of it, to conclude that this is a patent graft. For instance, Kieser's publications from 2010, based on 1,000 grafts, would support that. And if you take Kieser's data set and apply supervised machine learning to it, it will learn the similar conclusions as Kieser did. But then exploratory research, you look at huge data sets, searching for patterns, IDs, possibly also hypotheses to test later. And on the completion control of the LITA LAD, if you measure 8 milliliters per minute and maybe a PI of 10, you ask yourself why? What are the possible reasons for this? Is it competitive flow? Is there a flap in there, poor runoff, per string? You don't know. An experienced Medistim user will then turn to the shape of the flow curve, looking for indications to what could be causing this situation. And that is exactly what we try to solve now with unsupervised machine learning. But to be able to focus on the shape of the curve, we need to compensate for obvious differences. Like here, the mean flow and the heart rate. And the way we do that is that we normalize the flow curve, so every amplitude is at the same height, and we take out the heart cycles so we can compare different heart rates. This is an example of what we then get out of the unsupervised machine learning, a cluster of similar flow curves. So we see there are some similarities in there, but also differences. And then doing this on the whole request data set, so that is 1,016 patients from 7 sites, we get this cluster plot. So these 20 clusters, all of them have the same number of measurements in them. That means that the smaller the cluster, the more similar the measurements in there would be. Kind of looks like a flying bee, but is it meaningful? So we then took 460 patients of Torregrossa from Lankenau and compared the cluster plots. And at the first look, they look quite different. But an important aspect of these cluster plots is that it's not the absolute position of each dot, it's the relative. So we can try to place them on top of each other. And then we see there, it gets more similar, but still. Then we try tilting it, which we also can do. And then they start to look quite similar. But what about these spots left here, like the very dense segments of 18 and 11? So to the right, you see the average flow curves behind those cluster plots, and they are very typical of on-pump surgery. And knowing that Torregrossa is an off-pump surgeon, this supports that it might be a sensible plot. So then, where are we going with this project? Also, what is Medistim's ambition? And that would be to provide intraoperatively shape evaluation together with the flow parameters. So we took our guidebook, we have a TTFM guidebook, and the cases in there, and looked at some of them. So this is the SVG to the RCA, and then we did this shape evaluation. And you see that we find it, this measurement, the SVG to RCA, in segment 10. And these are 4 cycles in there, but they're all on top of each other. And that means that this is very repetitive, and it also means that this island is probably where good flow measurements live. This is an off-pump measurement, and it also maybe be for the right ventricle. We don't know, this is just one example, but it's very likely that good measurements, or measurements at 10, are indications of a patent graft. Here's another example, the radial to the PDA, a very spiky flow pattern here. And when we look at the cluster plot, we see that these 4 cycles from this measurement are spread out, which makes sense is in a spasm situation. So we learned that very wide cycles is an indication of a spasm. It's not a conclusion, but indication. And here, Alita to the LAD, again, very spiky flow. And we see that these 4 cycles now sit in cluster 1 and 19 and pretty close together. So this part of the scatter plot probably is representing obstructed flows. And this case required a revision. You now saw 3 examples, and we're in the very start of deciphering our Rosetta Stone. We maybe have 1 letter, and we don't even know how big this alphabet is. But we are seeking more data from Medistim users. So we use the request data in this experiment, but we need more representative data from all over the world. And obviously, we also need case examples, especially from difficult flow situations, to help us sort out more of these clusters. And to get there, we have established the cases study. The case study, all it takes is you follow your normal practice, but you label the graphs and you save the measurement and upload to a cloud solution. So Sigrid Sandner of the University of Vienna is in, Torregrossa is in, and we invite all of you surgeons out there to come join us to complete this Rosetta Stone. Thank you.
Welcome. Fantastic presentation. Definitely, Medistim is the leader in our field of a technology that is enable us to do a better job, care better for our patients, train the next generation of surgeons, train in advanced coronary surgery, first of all, off pump. I feel confident to let my fellow sewing Lima to the LED off pump because I can test that graft. And I believe it's extremely important owning your data and being able to understand pattern and even integrate all of this in the next generation of your own system to simplify even more the ability to predict what the graft is. From the work you're doing, how much do you think will be a clinical implication? How much will take to have a clinical implication of this work in terms of, like, give me an industry perspective. You have a...
Yeah. Yes, so the more and better data we get, the more precise we can be in defining these in the cluster plots and what it actually entails, right? So separating left side from right side and different patient groups, different sexes, etc., right? So, but to have just to look at the revision or no revision problem, which is
huge,
right? So we probably need, I'm guessing a bit here, but say 5,000 cases-ish. We will definitely have much deeper insight.
Yeah.
And then I think we can do very much unsensible stuff.
So serious appeal to the membership of ISCAS to join this Rosetta Stone project to provide data to this data set. AI only works on big data. It doesn't work on little data. We got to make this little bit of data into a really big data set so the AI can do what we want it to do. Thank you.
Thank you so much.
Moving right along, we have two more talks, and we were supposed to be done 8 minutes ago, so we're going to move quickly. The next speaker is Timo Weimar, good friend, who's the CMO of AtriCure. He's going to talk about the future of AFib surgery, which is an important topic in a coronary congress. I think we need to really talk about AFib and coronary disease. It's a different animal. Timo.
Yeah, thank you very much. It's a small field in our daily workspace, but it affects a considerably high number of our coronary artery patients as well. So I would like to give you a little bit, not the current status, but of a vision how we're going to proceed with that in the next 5 years. So I'm going to focus more or less on 3 patterns. Where do I see our patient selection in 2000 or in 2030? How do we develop our knowledge about atrial fibrillation, and how does that affect the effectiveness of our treatment, not only in device development, but also in pattern strategies that we develop. So the patient, and that's more or less a low-brainer we all talk about. I mean, Peter just said, what is AI? It's very hard to define. Actually, is it just a technology making our work easier by dealing with large data sets? Or does it really bring in intelligence in terms of can it make really decisions for us? So the identification process, that's a low-brainer that we can use AI for. That's already started, that we have software platforms to consolidate huge data sets on patients from different healthcare sources. So they don't slip through our screening. But AI will also be helpful in change definitions that are still given us from the guidelines, more or less. But if you run historical data through AI, you will see that our definitions are not necessarily the best. They are based more or less on the evidence we created. But just in terms of, we call it paroxysmal, persistent, long-standing persistent AF, that does not necessarily make sense to do those categorization in terms of being successful in the treatment. That's very interesting that we figured out from AI that we have to work on our definitions to become better, and that also reflects on scores that we use that are just certain parameters. AI is of course possible to incorporate many, many more indefinite parameters to move away from those limited scores to be more predictive in our failure rates and success rates for the future, which also reflects, of course, in the risk stratification that we have by our procedures. So yes, AI is tremendously helping in terms of neural networking with those identification and definition processes in the future. And I think this is where we're going to see the most advances in the next upcoming 5 to 10 years. So if we look now where I see us in 5 years from now, we will have software-based identification processes. The scores will change to not predefined parameters necessarily, because we forget and some parameters slip through our assessment right now. The current strategies, according to type of F, will change to a more pathology-based treatment. What does that mean? Now we're gonna have, and now we are shifting gears to what really atrial fibrillation is, and we still haven't understood the whole thing. This is another thing where I would say the next 5 years we have to work on to get a better understanding what this arrhythmia really means. But in terms of having a better identification preoperatively already, there is technology coming up that gives us in the OR the possibility to really have a real-time mapping of the patient that's available in the EP lab already. But we can do that completely uninvasive preoperatively or during our cardiac surgery procedure by epicardial mapping or imaging that can be done by electrode vests preoperatively or intraoperatively, and then we can design a more tailored approach to the disease AFib. This is already out there, but it's not incorporated on a more or less daily routine basis. Costs are one factor. The other is the interpretation knowledge. We heard about how important training is. And even if it's a small field, it affects about, 20-30% of our patients, AFib. We need to be on top of knowledge in terms to be able to provide the best treatment strategy and to be on an eye-and-eye discussion with our referral cardiologists and EPs. So here, I'm pretty sure that this imaging modalities will give us a better understanding of the pathology. I'm a little bit skeptical that we in 5 years know what AFib means, but it will give us a better idea and move from a more empiric approach that we have right now. We have very specific lesion sets for very specific types of atrial fibrillation. That will change to a more pathology-based approach in the next 5 years. We will have widely availability of those epicardial mapping tools. I'm pretty sure of this is just no one would start reconstruct a valve without a TE up front to get an idea of what's going on, and the same will happen in the space of AFib. So we, together with these mapping tools, also gonna have more effective electrophysiological endpoints that we can generate during the operation, so we know that we did a good job at the end of our procedure. So AI will be helpful there as well, more in this learning machine algorithms to help us to find the right approach here. This is still being supervised. I found that a very interesting thing to differentiate AI in terms of supervised and unsupervised. If you let AI right now run wild on something, this is not going to give you what you think you should get. This is a crazy thing that will more destruct, and I think it will take seriously 5-10 more years outside this hypothesis-generating thing to really have that unsupervised. But this is actually my definition of AI, of intelligence, that the machine or the network is doing your job of thinking, but it still cannot. It can deal with thousands of parameters, while I can deal with, let's say, 5, 6 at the same time as an engineer, but it still runs wild if you let it just do what it wants. So in terms of the treatment, of course, we are interested in developing technology and devices in terms of efficacy, also in terms of modeling a device design, in terms of being able to apply it minimally invasive through different access approaches, to be more anatomical, so it's getting easier for us as surgeons to use it in our procedures. And we also develop, of course, more reliable algorithm in terms of what we want to achieve. And right now, it's still the transmurality that we think will achieve the best results. So those are the three fields that is, from a technical aspects of the treatment and device development, important. And why is it? Because if we define an ideal device or ideal procedure from a surgical perspective, it should be efficacious, of course. It should be safe, that's very important, but it also should be simple, easy, and fast. And why is that? Because otherwise you will not create wide adaptability of a treatment strategy. So this is what AI right now is working on, to give you all of those 3 bullet points in the future upcoming device designs. And simple, easy, and fast, that's my vision for the next 5 years, that we are going to create those 3 bullet points to make, at the very end, adaptability bigger in this field. And generative AI is a very important artificial intelligence that we use for that. That gives us indications of, let's say, design changes that is not necessarily breathtaking new, but it will reduce our cycles, how we can bring up new products on the market, because those models work much faster. We get more options in a shorter time frame. So this is why I think you proposed it, Gianluca, yesterday, talk about the next 5 years. That's a very good time frame, actually, which should be a good time frame for new stuff to come up. And now the important thing at the very end, we talk about AI and development, but don't forget, besides the machines, it's still us who are responsible. And in terms of AFib, we have certainly knowledge that this is a very serious cardiomyopathy, meaning patients have a devastating clinical course if you don't treat it. A third gets heart failure, a third gets strokes. We know that, and we have this evidence, and that was reflected in the recent guidelines even. I mean, they do our job of compiling data, evidence out there, and saying you have a beneficial or a good benefit risk ratio, so you should treat them. They recommend it, and still this is how it looks like, that we only treat a third of the patients that enter our OR. So no AI in the world will change that if we don't change our mindset and treat according to pathology. So my vision for 2030 with that regard, despite the development that's coming from industry, is that we change that to a 90% penetration of the patient. That would be my main wish. Thank you.
Very nice, outstanding. I love this concept. You're right. We are talking about AI and the future realities that us as a surgeon are responsible for our outcomes, for the quality of the data that we acquire and we can provide you back to you, and most importantly, for treating our patients.
Yes.
And AFib is a great story of how surgeons for years have been completely dismissive of something that has probably more impact than choosing a radial or a vein for an obtuse marginal grafting in the cumulative 6-year or 10-year survival of that single individual. So thank you so much. It was a great presentation.
Thank you. Our final talk is from Glenn Bronkers, AMT Medical. Glenn is a good friend. I've been working with the company for several years now and had the opportunity to use this device in a cadaver intracardiac robotic, totally endoscopic. And he's going to tell us the nuts and bolts of the laser Ilana device. One of the things I'll say about Glenn, he's not a surgeon, he's not medically trained, but he has been in every case of the cases that he will describe because he's very knowledgeable about the device. Glenn.
Thank you, Sam. And thanks for the invitation to present here. I would like to take you on the journey from already 16 years ago now with the Ilana technique and the importance of physicians working together with the engineers. Because in my opinion, if they don't work together, there will be no facilitated anesthetic connector on the market available for everyone. We started in like 1999. Professor Tulleke, he invented the Ilana technique in neurosurgery. Also, the example here is that he was really knowledge and capable of making the anastomosis in the depth in the brain, treated more than 800 patients, but he was the only one who can do it. And for also example, for I think 99 of the seaport cases have done by Sam. So it makes more sense so that physicians and technicians work together on daily basis to make this happen. In the past, the Ilana technique, that's the advantage that we as a company have. It's the whole laser technology is already approved in more than 800 patients, CE, FDA approved. But yeah, I think 2008, 2009, there was interest also for cardiac surgeons. If you can make it in the depth in the brain, why not between the ribs on the beating heart? So as Peter said, like if you have a design, maybe one or 2 years, you can maybe go into clinic. But yeah, I just want to show you I started like in 2008 as an intern, working on the Ilana technology and make the whole development to eventually now the Ilana clip that is used in a clinical trial. So it was quite a journey. I really see it as my, yeah, I've got 2 kids, but it's my other baby. But it takes a long time. That's what Peter showed you. That ease of use, patency, a sutureless device. I think you cannot do it all in one. And then, yeah, there are also, like if you talk to Medtronic, they said like complete arterial revascularization off pump is interesting. Sam will say it's only interesting in a TCAP setting. In Europe, they say Rita harvesting with a robot, and then in a mid-cap. So it's quite delicate, like where you work on. I think we have to do it step by step. Just to show you, we start with the ring, then like so from 2011 till now 2017, we start with the Ilana clip. Did a whole preclinical trial, GLP trials. And eventually started 2021 with the clinical trial in Antonius Hospital in Utrecht. So what I showed, the technique itself consists of it's a clip and a laser catheter. The clip itself connects the LITA and the LED in this case together, and the laser makes the arteriotomy. So it's the whole basis based on also in neurosurgery. So no interruption of the blood flow, and you can always first test the connection and then make the arteriotomy, because like all the other devices that were there, and also compared to Handsoon, you first make the arteriotomy and then the connection. As a company, so what I said, we finished our SafeCap 1 and 2 trial. It consists of 82 patients who will receive with the Ilana clip LITA LED. So our final results will be available next year in August, and hopefully Bart van Putten from Antonius will present it on the ESCTS. Primary endpoint was there MACE. Secondary endpoint one of us was an angiogram. Later on, I've got some 2 examples of that angio. So it looks really promising now, the results. And now we closing our Series B round. To what I just said, like we want to approach it step by step. So we have now a single center. Also together, Bart and I did like 82 of all patients. what I just said, we need more sites, more physicians to be involved in the ELANA project. So that's why we are going stepwise. For example, now SafeCap 3, 3 other Dutch sites will be involved. We will do it multi-vessel, complete arterial off pump. Then the next step will be together, for example, with Charité, a mid-cap trial, first in human. With SAM, we will do a T-cap, so we will approach it step by step, and not to. I think the risk is too big to just give the device, for example, to Sam, and he said like, "No, this is not going to work." And, yeah, that will be our approach, and hopefully, of course, patency is the most important thing. I think we will, if we don't step by step, we will. We'll manage that, and hopefully it will be on the market soon. But our main goal is not that it will be on the market soon. We want to prove that it is safe and feasible in all kind of settings. Here is just some NGOs from. Now you can see here's the clip itself. So all the patency data will be available in January of all the 82 patients. So yeah, we're looking really looking forward to the results. Yes. Thanks.
That's excellent, Glenn, and thank you for showing the angiograms. I think the landscape of anastomotic devices was very, very rich in the early 2000s. I have a slide that I show that shows the number of patents that were submitted for anastomotic coronary devices back then, which was amazing, and they all petered out. And the only one that remained at the time that was available for clinical use was the Seaport Cardiaca device, and we used that extensively. And then that was taken off the market, and there was a huge desert in this field. And finally, now we have 2 very, very innovative companies from the Netherlands that have come back into this space, and I think it's a very important thing that we support all of these efforts with our ideas and applications and clinical research. And, you know, AMT is clearly in the advanced one in terms of clinical application. And so congratulations on completing the second phase of the clinical trial. Do you have a feel, Glenn, what the most important challenge was in terms of training a surgeon how to use this device? Because it does have its own nuances. It's a laser-activated device, and you kind of have to be very careful with it. What would you say is potentially a barrier to somebody learning how to use it?
Yeah, I think it's really the usability of the device. I think we now with the regulations, now also with the FDA on the MRI, usability is the main topic there. So I think it's good that it is there. So we really have to show usability, otherwise it will not be approved.
Yeah.
What I just said, those 82 patients I did together with Bart, so it doesn't show really usability yet.
Right.
That's why I think the main thing is training, but also the whole technology. It has to be, yeah, what we always said, like it has to be monkey-proof. I think that's the main, yeah, what we have to achieve, and the main.
Thank you very much. And thank you to all of the industry sponsors who have made this meeting possible and this session possible. I have found it really interesting. I hope that the developmental teams at each of these companies have had some benefit from this interaction. I hope that we're giving you frank and clear recommendations from our own perspective, and that is valuable to you because we have to move the field forward together. Now, we are way over time. One of the key things of moving the field forward is doing early recovery after surgery, and I'm asking Tom Schwann and Kevin Lobdell to come to the podium and try to catch up on the time as we bring our ERAS coronary program to the fore.